In this video we're going to talk about endocarditis. And endocarditis is basically a bacterial infection of usually a heart valve. So if we were to draw a very basic diagram of the heart chambers, left atrium, right atrium, left atrium, right ventricle, left ventricle, the heart valves are of course in these areas that I'm drawing. So this one here is your tricuspid. This one here, of course, is the mitral valve. This one here is a pulmonic valve. And finally, that one is aortic. And these valves allow blood to flow from one chamber to another, and they open and close. Now, the problem is that sometimes these valves can become infected with bacteria, and when that happens, it's endocarditis. Now, there's two factors that you need to have endocarditis. The first one is some sort of abnormality of the endocardium. Abnormality of endocardium. Endocardium, of course, is referring to the muscle of the heart. And what type of abnormalities? Well, really what we're talking about is abnormalities involving the heart valves. So that's the first thing you need. And examples of these include calcific heart valves, HV, prosthetic heart valves, those valves that I talked about very briefly earlier. There has to be something wrong with them, maybe a congenital defect or some sort of abnormality. So that's the first thing. The second thing you need is an introduction of some bacteria in the body. And the bacteria can get into a person's body either from an infection, urine infection, infection of the gums in your mouth, or some sort of catheter site, and very commonly in endocarditis cases, some sort of drug use, IV drug use, heroin addicts, for example, that inject heroin into their blood vessels with a needle. So those are the two things you need. You need some sort of abnormality of the heart valve, and you need some bacteria. And together, the bacteria goes and sits on the heart valve and causes endocarditis, which is a bacterial infection. So what are the symptoms? The symptoms are actually very characteristic. Some of them, of course, are common or non-specific, like fever and night sweats. Just being very tired, feeling a malaise, chills. That's another one. But there's some that are very specific that they talk about on licensing exams a lot. So I'm going to concentrate on those. And there's 4 of them. I'll try to make a little table here. So these are some of the more specific, the more like physical exam findings rather than symptoms. So the first one is called Roth spots. So what is a Roth spot? So this is a Roth spot is basically a retinal hemorrhage that you would see on a fundoscopic exam, retinal hemorrhage, and this is this can happen in endocarditis. It's usually either white or pale center, and when you do an eye exam, you can notice this, and it's given a special name, the Roth spot. The next one is called Osler's nodes, and what that is these lesions that you can get on your hand that are painful. This is the hand. Painful lesions, and they're usually red, and they're usually raised, and they're pretty characteristic. And they're definitely associated with endocarditis. The other one is called a Janeway lesion, and the Janeway lesion is similar in the sense that it's also a skin lesion that can be found, for example, on your feet. But the difference is that they're not tender, so they're non-tender, and they represent an area of necrosis, so they can appear black because it's essentially representing the dead dermis of the skin. And then finally, the one that the last one is called splinter hemorrhage. And splinter hemorrhage is referring to the nails. So if I were to draw, let's say, a finger, and this is the nail, splinter hemorrhages are these tiny blood clots that run vertically under the nails. So you'd kind of see them like that. And they're not completely and absolutely specific of endocarditis. They can happen in other conditions as well, but they can also happen in endocarditis, of course. And when you see these things, it's very characteristic. Okay, so somebody has the symptoms. You've found some pretty characteristic things on the physical exam. Now, how do you go about and diagnose it? What are the diagnostic tests? Well, there's four main ones that you need to do. The first couple are very basic: CBC and ESR. You know, CBC, you're looking for anemia, and you're looking for, these are very non-specific tests, but they're always ordered in a diagnostic workup of endocarditis. ESR is a erythrocyte sedimentation rate, which is a non-specific indicator of inflammation. Essentially, endocarditis is inflammation, and it will be elevated. But the next two are really the specific ones. Blood cultures, you need to identify the bacteria, and that's done with blood cultures, usually 3 sets over 24 hours. And finally, you need to identify the organism, you need to visualize the organism, vegetation that's sitting on the heart valve. So if we go back to that diagram, and let's say we have a vegetation, let's say, sitting on someone's heart valve, it would be visualized by the endocarditis, by the echocardiogram, sorry. So the echocardiogram is the diagnostic test that you do to visualize the vegetation, which I've drawn, and the blood cultures is what you do to isolate and identify the actual organism. So, how do you treat it? Well, the mainstay of treatment is IV antibiotics, and there's a long list of antibiotics and antibiotic regimens that you can use, but I'll break it down in basically 3 categories. The first one is IV drug users. IV drug users most commonly are infected with an organism called Staph aureus, which is very famous. And when that happens, they're given anti-staph penicillin. Anti-staph penicillin. And those include nafcillin. There's others as well. Nafcillin, oxacillin. I encourage you to read about anti-staph penicillins. Nafcillin is probably the most common. Oxacillin is another one. Oxacillin. But that's the first one. Second one is if you have MRSA. MRSA is an organism, methicillin-resistant Staph aureus. And if that is identified as the causative bacteria, then you would give vancomycin. And vancomycin is given with gentamicin. So I'm trying to make this not too complicated, because endocarditis regimens are very, very, there's many of them, and the tables that they often list have so many. So I'm trying to break it down into just 3 basic regimens. And the last one I want to talk about is when you have these mechanical valves. When people have mechanical valves or previously damaged valves, there's an organism called Strep viridans, and that is treated with ceftriaxone. Ceftriaxone with gentamicin. So I don't think this is too difficult to remember. It really kind of narrows things down, and I think for most board questions you'd be okay with this list here. Before I get into a couple clinical vignettes, I just wanted to mention just the last few important points. People with endocarditis or history of endocarditis or a risk of endocarditis need to have something called antimicrobial, if I can spell it, antimicrobial prophylaxis before certain procedures. Now this is a very important point. What that means is that before certain procedures, people with prosthetic heart valves or people with previous endocarditis need to be given antibiotics. So a typical scenario is somebody had endocarditis, let's say, some years ago, and then prior endocarditis, and then they're going for a dental procedure. Now, if you remember earlier in the presentation, I talked about how bacteria can be introduced into your bloodstream from your gums. So if it happens, it could lead to another case of endocarditis. So to prevent that, you give antibiotics prior to the dental procedure. So that's what they mean by antimicrobial prophylaxis. So now I'd like to talk about a few clinical vignettes, and here we go. 27-year-old man comes to the emergency department because of increasing fatigue, malaise, chills, low-grade fevers in the last 2 weeks. No recent sick contacts, denies any significant past medical history. Patient does mention that he uses heroin frequently, but not since last week. His temperature is 101, blood pressure is 85/60, heart rate is 120. Physical exam, patient appears gaunt, malnourished, and dehydrated. Faint systolic murmur is audible. Needle tracks are found on both arms. Petechiae are noted across the back, and splinter hemorrhages are found under the nail beds. Lab studies show, I didn't include them, I didn't have enough space, sorry about that. Chest x-ray is normal, EKG, sinus tach, UA shows some protein, red blood cells. Patient is admitted to the hospital where he becomes progressively more confused and disoriented. 3 sets of cultures are drawn and fluids are initiated. Most appropriate next step is, well, this question has given you a lot of information pointing to endocarditis. There's no doubt about that. So now you have to figure out, what do you do next? Well, I think it's a good question, and I like it because it kind of makes you think, okay, what category is this person in? And it clearly tells you he's an IV drug user, and there's needle tracks as well. So if you remember, for IV drug users, the most common causative organism for their endocarditis is Staph aureus, and it's treated with anti-staph penicillins. And anti-staph penicillins include nafcillin and oxacillin. So the answer to this is right here in choice A. You need to initiate antibiotic treatments immediately because the patient is becoming progressively more confused, so he's deteriorating, so you don't want to wait until the cultures come back. Next question. Next question is a 30-year-old woman with hypertension, migraines, history of IV heroin use, comes to the ED with shortness of breath, cough, and weakness for 10 weeks. Her medications include sumatriptan and atenolol. Blood pressure is 100, temperature is 100, pulse is 100, blood pressure is 130/85, respirations are 12. Physical exam reveals a previously undocumented systolic murmur, grade 3 to 4, over the left sternal border, and splinter hemorrhages of the fingernails. Lungs are clear, lab tests are pending, electrocardiogram demonstrates sinus tach. Treatment should commence with the tentative diagnosis of. So this question is pretty straightforward. It's just basically asking you, what do you think this patient has? Well, there's a lot of clues. IV drug use. She's got a bit of a fever, splinter hemorrhages. This murmur, and the previous question talked about murmurs also. Murmurs are evident on cardiac auscultation when a person has endocarditis. It's a physical exam finding. So this question is pretty straightforward, asking you what is it, and it's of course endocarditis. And finally, well, this one I ran out of space, but I'd like to put in the answer choices. It's always better. So let's see, you got A, B, C, D, and E. So this question, this one, A is an echocardiogram showing mitral regurgitation, an echo showing vegetations, an elevated erythrocyte sedimentation rate, a positive VQ scan, and finally a single positive blood culture. So those are the answer choices. So let's read the question. 44-year-old man comes to the ED with 7-day history of fever and 2-day history of red spots on his eyes. I'm assuming those are the Roth spots. He also reports some lethargy and fatigue. His past medical history is otherwise unremarkable. He does state that when he was a teenager, a physician once told him that he had a heart valve problem that would require him to take antibiotics on dental visits. Okay? Temperature is 99, blood pressure is 140 over 75, pulse is 92, respirations are 16. He has bilateral conjunctival hemorrhages and small indurations present on the dorsal surface of his hands. He has a 1 out of 6 grade systolic ejection murmur and heard best at the apex. The finding most likely to confirm the diagnosis is, okay, well, he's got a fever, he's got a history of a heart problem, and he has a murmur, and he's also got these characteristic physical exam findings. So it all leads to endocarditis. Well, let's go through these. VQ scan actually refers to a test that you do to diagnose pulmonary embolism, so that's probably not it. Single blood culture, well, if he has endocarditis, it probably all the blood cultures will probably be positive, so probably not E. Elevated ESR will definitely be part of the diagnostic workup, but it's not the most likely. It's not the test that you do to confirm it. So now you're left with A and B. Well, if you do an echocardiogram and it shows mitral regurg, that doesn't confirm endocarditis. You have to actually do an echocardiogram and see vegetations or some sort of mass on the valve, and that will confirm that this patient indeed has a bacteria that has infected the heart valve. So the answer is B, which is an echocardiogram showing vegetations or a valvular mass.